I mean, today is just, sorry for all the technical difficulties. It's quite challenging doing the lecture at the same time. I hope you guys understand. But more so, it's also quite challenging to present a very big topic on the lower back on a very short period of time. So we'll try to make it as concise as possible. And whatever questions you have, feel free to email me or anything. And I'll try my best to answer back as soon as I can. Or even for today, if you have any questions, let me know. I want to make sure that you guys have a better grasp of it, of back pain or of treating lower back as much as possible. So with regards to back, I'm sure everyone has treated a lot of back pains.
Yes.
And how do you find it? Quite challenging?
How do you find it? Challenging, but sometimes it gets too routine because of the prescription of the doctors.
Yeah, I'm for that. It is quite challenging for a lot of us because our clinical practice is quite different in terms of how we manage patients. And it limits the ability of the therapist to become, creative in how to treat the back, since we try to be more modality dependent rather than exercise based. And for back pains and for other musculoskeletal conditions, it's always the best tool is always exercise, not so much modalities, and that's been proven with many studies already. Unfortunately, because of our situation, it really depends on how good your rapport is with the doctor. If you have good rapport with the doctor, then you can maneuver yourself away through doing different stuff. However, if the doctor is clear-set and close-minded, it's going to be harder to change the protocol or the routine that you want to do. And for clinicians, it hampers your growth too, because you cannot do what you want to do and see the results that you want to do in order for you to learn and manage patients better, because the patients that you see in itself are the ones that are teaching us how to become better clinicians. They're the ones through our experiences with them, through our encounters with them, will help us grow as a clinician. And yeah, unfortunately, in the situation natin, it's harder. Well, we would like to try something out, but can't because the doctor won't let us do it. Alright, so do you see the set of slides that are, I think we're trying to put the slides, are the slides there, Sir X?
Yes, sir. They can see the slides.
Okay. Alright, good. Let me just pull out mine for a second here so that I know what I'll be talking about each slide. Okay, so lumbar anatomy and biomechanics. So this is the first page. This was a presentation that I did way back in 2001, because at the time na bumalik ako sa Pilipinas, naggawa kami ng maraming seminars on low back and different musculoskeletal conditions. So if we go to the next slide, you'll see that this is based on a very good book, and I would suggest that you try to read it if you really are keen on learning a lot about back. I think they even have a 4th edition right now, so a more updated version. A lot of the things that are being mentioned here are in the book as well, so you might want to refer to the book because it's really a good resource for you. And there are other pictures here that are from different resources as well. So on the third slide, so you see a view from the top view, a top view of the lumbar bone. Basically, you have a lot of parts involved in it, and if you see that there's an NA here, which is on top of your vertebral foramen, that's actually your neural arch, is what we call the neural arch. So that neural arch is just a support strut to protect your spinal cord, to make sure that you don't injure it in many ways. So you've got different parts involved here in the neural arch, and these are your posterior elements. Your posterior elements basically have your facet joints, meaning your superior articulating facet joint or process, your inferior articulating process, your lamina, which is like the roof of your spinal cord. You've got your spinous process that's there. And then you've got also transverse processes which go out to the side. Alright, so basically your neural arch protects the spinal cord. Right? So if you go to the next slide, which is our fourth slide, you see here that you've got posterior elements which are on the back, and you've got a pedicle which is in the middle between the vertebral foramen and the posterior element. Now, if you think about it, your back takes a lot of load. It takes a lot of amount of force. And if you think about it, if the force goes from the front to the back or back to the front, you need a bridge that's very strong, sturdy, and thick. So that's what the pedicle does to it. It helps keep the front part and the back part attached together. Now, commonly, you would find in older patients, compression fractures, diba? Yung pag nahulog sila, trigger a compression fracture, and that's commonly seen in the vertebral body. So what happens when they fall, the height of the vertebral body just gets compressed. So they get pain, severe pain, even sometimes radiating pain down to the leg, depending on the presentation. Now, normally, some of the doctors would just immobilize the patient with, trunk AFO, or not AFO, a trunk orthosis or mga spinal braces, just to prevent them from moving excessively and hurting themselves. And then in between, as a therapist, you just need to build up the strength on the lower legs. And if you are daring enough to try it on the core, you may do so, but you want to make sure you don't aggravate the pain. And you have to have a very good respect on what your trunk muscles are capable of generating every time you provide exercises. Because if you do any arm exercise, it doesn't mean that it's specific only for your arm. Your core will always be involved. Most of the time, majority of the time, your core will be involved. If you move your legs, you move it in a certain direction, it's not just a specific muscle that will move. It will involve your core to contract as well. So make sure that if you try to do rehab on certain patients, you also respect the fact that you may activate some of the core muscles. And if you have injury on the back for these patients, you might want to be careful on how much you want to do the exercises so that you don't aggravate their condition. And if they do aggravate their condition, then it's a learning process. That means what we provided for them in terms of exercises may be too much. All right, fifth slide. So this is just another side view of your lumbar vertebra, and it just shows you have your inferior articulating facet just down below the spinous process, transverse processes. All right. So number 6 slide. So basically, in terms of joints, so we went through the bones, and now the joints. There are 2 basic joints that you will find in the lumbar spine. You have the anterior and posterior part. Obviously, the posterior is where you have your facet joints. Your superior articulating facet and inferior articulating facet. And the anterior vertebral joints is just between the vertebral bodies, the joint between the vertebral bodies, which is separated by your intervertebral disc. So if you go to the next slide, which is number 7, you'll see a very good picture of the facet joints, or what they call Z joint. Do you know what the Z joint, right? It's like the apophyseal joint. It's the same banana, but difference in terminology. So facet joint, or some people will say Z joint. They would say Z joint, which is your zygoapophyseal joint. It's just the joint between the 2 bones from the posterior part. So you can see in the diagram that it's a joint capsule. You have articular cartilage within the joint. There's a lining inside that. And sometimes inside the joint there are fatty tissues also that you have to know. So those fatty tissues can get impinged. So that's why you would have like catching pain when you by accident nag-move ka and nag-turn ka tapos biglang sumakit. So minsan pwedeng magkaroon ng sinasabi nila yung fatty deposit inside the joint na iipit. So kaya ka nagkakaroon ng pain or sudden pain when you move in certain directions na sometimes they say you manipulate, it helps. Sometimes if you manipulate, it gets worse. Now, given about manipulation, my opinion about it is it's not the end all and be all for your treatments. Yeah. Initially, when you learn it, it's nice to know, but in practice, you're not going to always use it. It's not always the end all and be all of your treatments. It shouldn't be the end all and be all of your treatments because not all patients will have the same kind of response when you do the treatment. One patient can have a severe response, one can have a good response. So there are clinical guidelines on when to do manipulation, especially on the lumbar area. There were studies done way back. What's her name? Julie. She's from Utah. Anyway, but yun, clinical practice guidelines, or CPG, they call it, or something like that. There is a specific set of mga guidelines kapag ganito yung pasyente and all of you have three out of the five categories then you can do manipulation. Kasi hindi lagi talaga yun ang ginagawa. Like a lot of chiropractors use this as the end all be all of their treatment when in fact it's not always the case. Sometimes they aggravate the patient's condition even more. So bear that in mind because as you grow in your clinical practice, you will see this and you will realize this. Okay, next slide, number 8. Like what we mentioned, you have the anterior intervertebral joints. It's just between the two vertebral bodies with the ivy disc in between. Alright, next slide. This is number 9 now. Nakita niyo ba?
Yes po.
Yung slide?
Yes.
Okay. So, at least nakita niyo visually. So, you have your nucleus pulposus, which is the centermost part of the disc, right? Your annulus fibrosus, which is the outermost part of your disc. So, it's very collagen-based. And then if you go to the next slide, you know, your ivy discs basically has 3 basic structures. You've got your glycosaminoglycans, proteoglycans, and collagen. Now, do we need to know all of them? No. But if you want to go to research, maybe, but we're not going to spend a lot of time on it. Okay. So just basically, there are 3 parts into the disc that you have to respect. When we move to the next slide, which is number 11, so we're now looking at what's going to happen, let's say, when we put load on your disc or your vertebra. So normally you get a compression on the ivy disc, and what happens to compensate for that compression, it's going to expand radially. So meaning, lalapad siya. Once na-compress, nakita niyo ba ako? Hindi, no? Okay lang yan. Okay lang. Alright, just leave the... So if you... So, sige, can we look at the video or transition to the video? Wow.
Wait lang po, sir.
Sure, sir.
Starting.
Yeah. Bigyan mo lang ang cue yung kailan.
Yes, sir.
Baka naka... Gala ka lang. So, if ever... baka na.
Sir, wait lang po. Nag-start po yung video.
Okay lang.
Mas may
Nagdag na siya.
Okay lang, sir. Kahit tawag na lang. Okay lang.
Sir, ayaw po mag-start yung video. Sorry. Okay po, sir. Ayaw po. Ayaw po yung
Ito na lang.
video.
Di ba may salvabid? Marami tayong salvabida sa Pilipinas. Diba?
Opo.
May salvabida yung parang interior ng gulong. Diba? Di ba pag higaan natin yan, ano nangyayari doon sa salvabida? Di ba bumabaksak tapos lumalakad din? So it's the same manner with your ivy disc. If you put load on it, it's gonna expand radially palapag. That's what it does, basically. Right, on the next slide. So if you look how the tip also moves when you distract the different parts or different areas of the disc will move in equal distances. So it will start opening up more. You know, if you have a patient that has stenosis, and let's say a patient who has stenosis would be an elderly patient on the lower back. So that means what? Pag may stenosis, What does it mean?